Hello. Just letting everyone, if you can find a seat, we'll get started on time because we have a lot of great information to share with everyone today. All right. Our talk is going to be a lot about collaboration between multiple CF care team members and their unique perspective on bloating. So we're really excited that you're all excited about it too. I've had the honor of working with these great presenters for the past few months. I've met most of them about half an hour ago in person. We've been Zooming for a while. And we really want all of you, we challenge you to think of each individual presentation as the reason and the solution for bloating. And our presenters will present their viewpoint. So just kind of thinking of that point, counterpoint. We'll take our time introducing, sorry, I guess I should have done these things. Each presenter as they're going through. And then we will have all the questions at the end, kind of as a group discussion. So if you can please, this session is being recorded. So if you could please use the app or some microphone there and there at the end if you have any questions, that would be great. Okay. Okay. Yeah. So our first presenter is Dr. Dhiren Patel. He's a professor of pediatrics and director of the Pediatric Gastroenterology. Sorry, I'm really nervous. Big words. And colorectal pelvic reconstruction program in the Division of Pediatric Gastroenterology at Cardinal Glennon Children's Hospital, St. Louis University School of Medicine. He specializes in caring for children with GI dysmotility from various causes, including CF. Dr. Patel is a past CF Foundation Digest awardee, an active member of NACFC, and serves on the NACFC Planning Committee. His clinical practice integrates advanced diagnostic and therapeutic technologies such as pH impedance testing, high-resolution manometry, neurostimulation, and targeted Botox therapy for the anal and pyloric regions for GI motility disorders. His ongoing research focuses on disorders of gut-brain interaction and GI dysmotility in patients with CF. And we're honored he could be here today.
Thank you, Daniela, for that great introduction. Hello, everybody. Hope you're enjoying the lunch. I see no seats there. Hopefully they can get some more chairs in. These are my outline. If we're going to talk about the bloating, we have to talk about the physiology of gas production. We'll look into bloating versus distension and abnormal motility, which we will refer dysmotility from now on. Bloating specifically in DGBI, which is disorder of gut-brain interaction. Clinical approach to bloating. We will not talk about SIBO, diaphragmatic breathing, and diet in this talk, since it's going to be covered with later talks. These are my disclosure of several grants from CFF, Digest Leadership and Planning Grant. So definition of bloating. So it's a subjective sensation experienced by patients, and Rome 4 criteria says that you have to meet both of the following. Should be recurrent bloating and distension on average 1 day a week, and this should happen for 3 months, at least 6 months prior to diagnosis. And there are insufficient criteria for IBS, functional constipation, diarrhea, and postprandial distress syndrome. So why does bloating matter in PWCF? So this is hot off press. Nearly 2,000 CF caregiver, clinician, the entire community voted. And the strategic planning committee found out that the top research priorities and the symptom burdens both are digestive issue and aging, especially after ATIs. 40% of respondents indicated that moderate or severe burden with bloating, gas, diarrhea, constipation, and pain. Clearly, bloating does matter at this point. So let's talk about the physiology of gas production. How do we get the air in our body? Either we swallow a lot of air or drink carbonated beverages, or while talking, any normal physiologic activity. Now you have a lot of gas in the stomach. Lower esophageal sphincter is going to act as a pop-up valve. You're going to belch, let the gas out. Whatever did not come out, you go on to develop mix with the hydrochloric acid in the stomach and goes in small intestine. There produce carbon dioxide. So moving on to small intestine, carbon dioxide, oxygen, and nitrogen, those are the predominant constituents of the gas, the gas type. And if you look at carefully, carbon dioxide and oxygen actually diffuses very good. And that's one of the reasons why GI doctors use the carbon dioxide instead of air at the time of scope. Nitrogen actually does not diffuse through the intestinal wall. In fact, you get some more air from the bloodstream into the small intestine, thereby increasing the burden. How else we can get the gas in the colon? The food that we eat. Bacteria are friends. It produces via fermentation. Not only short chain fatty acid, but some bacteria actually consumes and releases several gas, including hydrogen, carbon dioxide, methane, and hydrogen sulfide, and ammonia. So out of all this gas that we swallow or bacteria produces, only 23% is evacuated from the bottom, which with predominant content of nitrogen. The rest depends on what kind of bacterial flora you have or gut microbiome and your diet. And some of them is going to be expelled by mouth with belching. So we know that physiologically we have more gas in our body. So if you look at the left picture, fasting functional scan shows 94 ml. Fed state after eating 150 ml. So there is a lot of, there is some increase, I wouldn't say a lot, but some increase in gas. So why are we not feeling bloated every single day? Well, we are designed to perceive, to not perceive these changes, with two main reflexes. One, your diaphragm should go up and abdominal muscle wall contracts. So we don't actually feel this is bloating after eating on a day-to-day cases. So it's a subjective sensation, pressure that may or may not be accompanied by distension. So you can have bloating without distension, you can have distension without bloating, or you can have both. So why is this important? 85% of patients with functional GI disorder, which is now known as DGBI, so it was previous name, the nomenclature has changed now, reported some degree of bloating. So this is extremely common, not only in children, but in adults too. So how do we approach this? Like any other chronic disease in your office, we should rule out other things. His celiac disease been ruled out. Is there unexplained anemia? Is there unintentional weight loss, bilious vomiting? And we all realize that as much as this is bothersome and annoying to patients, long-standing chronic disease, but usually marker of benign disease. CF, however, is a bit different situation. We'll get there in a minute. So when you look at the gas, you have to define in your mind, is this real increase in volume of gas like aerophagia, meaning swallowing of air, or dysmotility? Or this is redistribution or impaired handling of gas, such as DGBI, bacterial overgrowth, or malabsorption. Looking at this X-ray, in general, volume of gas within the small bowel is low. So you can have gas in the stomach, you can have gas in colon, but small bowel generally does not carry significant gas. So if you look at the big X-ray like dilated bowel loops like this, it's concerning, particularly in pediatric, which is what I practice a lot. Luckily, these are extremely rare, and the disease like pseudo-obstructions are not going to be your day-to-day office visit in bloating. So looking at this healthy volunteer colonic gas infusion study, you can look at the left picture. Can you see it? Okay. You can see the diaphragm should go up. So basically they take the, healthy volunteer and they infused gas and looked at the MRI before and after. So you can see the diaphragm pushing up and you can increase the gas volume, and volunteer did not feel discomfort. But again, these are healthy volunteers. Then Spanish study, Malgelala, from Spain, did a very interesting study. They took patient with bloating, call them in office and just say, do you feel bloated right now? They said, no. Okay, well, you're getting the CT scan right now, that the baseline, and here is the pager number. Come back, call us when you feel bloated. They call, the study was conducted, and they looked at the difference between volume between pre-bloating and the bloating. And the difference was only 22 ml, which is not really significant to justify the distension that we're seeing in patients. So it becomes a real estate problem, not a gas problem. It's location, like real estate folks says, it's a diaphragm descent that is causing more problem. Something known as abdominal phrenic dyssynergia. And I think Chris is going to teach us about the, diaphragmatic breathing in just a second there. So this is different than true motility disorder, where you have pseudo-obstruction-like conditions, where you have baseline high gas content. You can see the baseline increase in the gas, and during acute flare or those episodes, those patients are like 4 liters of belly in their, stomach, and that is like visible distension, which is also not comfortable. However, increase in normal, scenarios does not justify. So x-axis is abdominal perimeter, y-axis is gas volume, and you can see there is no significant correlation between the distension and the volume of gas. That's different with aerophagia. A lot of kids do this. You can see big gastric bubble, so it's clear pathognomonic, signs of aerophagia. You've seen all of this, toddler belly, right? Why? They're not angry. They go on with their lives on a day-to-day basis. Nitrogen is poorly absorbed from the intestinal lumen, and that's why they swallow air full of nitrogen, and their belly is, distended like this. Does it only have to be kids or toddler? No. Aerophagia in adults, also in comparison with functional dyspeptic patient, belching and bloating were most common symptoms. So you can argue that bloating or belching might be also one of the manifestations with adult aerophagia, where anxiety was significantly higher in patients with aerophagia. What do you do when you're anxious? Hyperventilate and increase breathing, swallow a lot of air. So we, are designed to actually tolerate a lot of gas, if it's consensual, and I'll get to it in a minute. But 30 ml per minute, they literally took the NG tube, blow them up, and saw, no discomfort up to almost 30 ml. It's a lot of gas. So if gas handling is impaired, and in terms of like propulsion is, inhibited with glucagon, but there is no obstruction, you have intestinal lumen intact, you're going to have distension, but it is well tolerated without discomfort. If there is a flow to resist or any resistance to the outflow, you're sitting here, this is not a good environment to pass the gas, or kids in school, we have increased resistance because self-restraint. You're going to feel that, and that is going to be uncomfortable with that, even though there is no distension. So to me, bloating is just an expression discomfort below the threshold for pain before it becomes actual pain. So we're supposed to have postparental accommodation. Gut relaxes in a way that moves the food without you knowing this. Visceral hypersensitivity, or DGBI, converts these actions, such as bloating and other DGBI symptoms. So what are these DGBIs? Thanks to Chris for lending me the slide here, but this is a spectrum of disorder on IBS to functional constipation to bloating to functional diarrhea. But the more important thing I want to talk about is on the right side, biopsychosocial conceptual model. Basically, this is a dynamic interaction between your early life stress, psychosocial factors, and physiology of your GI tract. And you can read those, factors individually, but this is going to determine how DGBIs are going to present, how much quality of life impairment you may have, and what kind of outcome you are going to have. I explain this to patients where I say your GI tract and brain is connecting, but in a little bit of an exaggerated fashion, where the stimulus to other patients without the problem is 2 or 3 out of 10. Your gut senses that six or seven or eight, 9 out of 10, without any actual pathology or organic disease. So one of the most important thing Rome criteria probably contributed, in our definition is that they made the DGBI diagnosis as positive. Instead of saying that, no, I have not found anything, therefore you have DGBIs, we probably should stop saying that. We should say, it seems that your symptoms are consistent with this known disease. Let's discuss the treatment of this. And this raises big question. Is there chronic abdominal issues in CF? Is it the time to call it a DGBI? Going back to the same picture again, is that real increase in volume or redistribution? People with CF has some different, alterations there, right? We can have dysmotility, but you can also have other things, including DGBI, SIBO, or malabsorption. So that brings the important topic is that DGBI in CF2, knowing that we also have CFTR dysfunction. These are the reason why maybe it is time to think about this. Individuals with CF may have visceral hyperalgesia, and symptom may be amplified by stress, mental, behavioral conditions, like everything else, in normal patients. If you exclude the stipulation that CFTR mutation cannot be counted as a, IBS, then many people with CF meet the criteria for DGBI. The treatment modalities for DGBI could be very much effective, which we are not probably offering to some of these patients, like neuromodulators, antispasmodics, and many chronic diagnoses like inflammatory bowel disease, celiac disease, eosinophilic GI disorder, they have higher prevalence of DGBI, and we have seen that over and over. You can see, I'm not going to summarize all the slides, but it's IBD, celiac disease, eosinophilic disease. All of them has functional GI disorder or gut-brain interaction, very commonly found. This is the only study I could find for DGBI in cystic fibrosis in pediatrics. It's a cross-sectional study where they enroll patients over 4 years or so. CF controls were enrolled from their ophthalmology or ortho clinic, nothing to do with the pain. They threw Rome criteria on them and just kind of casted a wide net there, and found that 36% patients, as opposed to 10% control, had DGBI. Commonest one being functional abdominal pain, which suggests that maybe higher prevalence of DGBI even in cystic fibrosis, and we may have to start routinely screening and provide the targeted treatment in CF care. Baha, Moshri, and other colleagues published this guideline on the approach on the bloating, and this is too extensive just for the talk of today, but there are a few things being covered later in the session. I want to focus on few things. Physical activity, even if it's lighter physical activity, you can see on your left and right or left chart where gas infuse in the body and in both resting state and exercise state. And then on your right is a perception score, how you feel. Patients who had, done even a slightest physical activity, they felt less bloating, and it doesn't have to be too long. Walking 10 to 15 minutes after meals is sufficient, will make it significantly better. Promote evacuation. If your patient is constipated, treat that. It doesn't have to empirical treatment. You have to, look at it clinically, but prolonged balloon expulsion test on anorectal manometry has been associated with the distension patient with constipation. How do you treat the DGBI? You have to either aid visceral perception or modify the reflex response. How do you do that? Cognitive behavioral therapy is your friend. Your psychologist, can really teach these patients a lot. You can prescribe neuromodulators, antispasmodic like dicyclamine or Levsin or those kind of medication. Complementary medicine, peppermint oil, iberogras, some of those medications are super helpful. Not everything is, again, insurance covered and all of that. There are some problems with all of those, but there is no reason not to try them. And modifying reflex responses, again, diaphragmatic breathing and biofeedback. So in summary, this is kind of important. If you did not pay attention after the lunch coma, you can just look at this. Abdominal distension patient, you have to ask, is this persistent or intermittent? If it's persistent, it's a problem. It could be an obstruction. dysmotility ascites, and it could be still body habitus, but we have to look at a little bit more closely. If it's intermittent, who does it bother more? To patient or parents? Because I'm a pediatric GI, we have many parents are bothered, not really patient like we saw. If it just bother parents and it's an intermittent, really, it could be arophagia, low tone of the body habitus. But if it's persistent and if it does bother patients, it's not unreasonable to rule out celiac disease. You can get the lab test for celiac and upper endoscopy. And I think this next question might change the perspective, whether you have diarrhea or no. If you have diarrhea, that could be malabsorption, pancreatic insufficiency, bacterial overgrowth, all of your, normal diagnostic list. But it still could be DGBI. But if this is not associated with diarrhea, it has to be DGBI, either associated with meals like functional dyspepsia, irritable bowel syndrome, food intolerance, non-celiac wheat sensitivity, and rumination. And if it's not associated with meals, you have IBS, other DGBI, like we saw the whole list, and arophagia. And to me, all this converged to, learn more how to regulate your behavior, diaphragmatic breathing, physical activity, treat the constipation, neuromodulators, and cognitive behavioral therapy. Trial a FODMAP diet or any eliminative diet, restrictive diet, I would keep it for last, because we saw many evidence that, gas production is not the only reason why you feel bloated, and it is actually hypersensitivity. We are now seeing more and more patients with ARFID and eating disorder. So trying to eliminate the diet from the patients, it should be the last thing unless absolutely necessary. And it could be, such as celiac disease. No problem with that. But unproven restrictive diet is, going to hurt your weight, and it is isolating socially. We're not able to eat things, in the gathering and the public and things like that. What is still unclear? K-pop demon hunters saying 6'7". If you know, the rest of you, I'm sorry. And this is something, and I really found 6'7" restaurant here, so So going back, what are really unclear? Is there a concurrent bacterial overgrowth? Is there really a dysmotility? We don't know a lot about motility. We know motility pattern in many other diseases, but not quite in CF. And what is the role of gut microbiome and antibiotics? How is this ETI and other newer discoveries that's happening, exciting discoveries in CF world, how is it going to affect the bloating? Because as of now, we're seeing no difference, right? Sarajan is here. We looked at all the data, and, GI manifestation has not been changed, after long treatments. And with that, and thank you and gratitude to my family who is here today. They're cheering me up. And full disclosure, 6'7" comes from them. Okay? And countless patients and children and family with CF who we build our career on. My mentors and collaborators, CF Foundation, who had graciously funded me for a long time. Jose Garza and Chris Velez, who lended me few of the slides. I'm not this smart. And Cardinal Glennon and SLU CF Center. And with that, we will do any questions later. So.
Thank you for that engaging talk. So here we had from Dr. Patel a description of the CF-related GI complaints that a lot of us take care of as being within the spectrum of disordered gut-brain interaction. I have the pleasure of introducing the next speaker who's going to offer the opposite view, that that's all hogwash, and we should be focusing on the fundamentals of CF-related GI care, which are the organic structural basis. And as you can probably imagine, based on what Daniela said at the beginning, it's probably the truth is somewhere in the middle, but we're going to hear the opposite approach. So I have the privilege of introducing the next speaker, Dr. Kirthana Kesava-Brepu, who is a Digest 4 recent alumna from the Cystic Fibrosis Foundation and my mentee as a member of Digest faculty. She is an assistant professor in the Division of Adult Gastroenterology and Hepatology and the director of the Center for Metabolic Health and Weight Management at Rutgers School of Medicine in New Jersey. She is a past CFF Digest awardee. Her clinical and research interests are centered around integrating nutrition to modulate microbiome and intestinal symptoms. Hello.
Hello, thank you for the introduction. I wanted to thank the foundation for inviting me to talk about those very frustrating symptoms and my fellow panelists who will address bloating from various angles. I have no disclosures, but I am part of the last Digest cohort. And today I'm going to talk about organic or pathologic etiologies of bloating, the role of constipation, dysmotility, and dysbiosis, and how laxatives, prokinetics, and antibiotics can impact bloating symptoms. Like we've mentioned, there are multiple structural and luminal disorders that can result in bloating and should be evaluated, but we must consider intestinal dysmotility, bacterial overgrowth, food intolerances, and malabsorptive diseases. Now, I'm not going to focus on all of these things, and they will be addressed in the next talk. So constipation is one of the most prevalent, most common GI complaints in children and adults with CF, with a prevalence of up to 54%. So that's up to 3 in every 5 patients with CF. The etiology, like we've heard in so many talks here, is linked to the loss of CFTR, its alterations in the level of chloride and bicarbonate in intestinal fluid, and the resorption of sodium and fluid from the lumen, resulting in dehydration of luminal contents and subsequent constipation. So the definition that the guidelines give us is this gradual accumulation of stool throughout the colon, leading to symptoms such as hard stools, abdominal pain, and bloating. And here you can see compacted stool on both the right and left colon. So constipation is impacted or impacts motor function. So this is a 3D model of the colon, and you could see the amplitude on the top, the frequency on the bottom, and healthy controls on the left, and patients with constipation on the right. And in healthy patients, the transverse colon to distal descending represents this region of highest amplitude and frequency of propagating pressure waves. In contrast, those patients with slow transit constipation exhibit no increase in this amplitude and reduced frequency of propagating pressure waves in these regions. And multiple studies have shown us that in slow transit constipation, there is this reduced colonic propulsive activity and increased uncoordinated motor activity in comparison to healthy controls. When we think about what's happening in motility in CF, mouse models show us that there is impaired circular muscle activity with erratic variable frequency of contractions, resulting in this delayed small bowel transit. It's worsened by bacterial overgrowth, and it's eradicating bacterial overgrowth improves transit rates. Similarly, oral laxatives also improve intestinal motility by improving circular smooth muscle function. In patients with CF, utilizing various methods of transit analysis, we see that patients with CF have delayed small bowel, total colonic, and segmental colonic transit. You can see in the table on the top that total and segmental colon transit times, specifically the right colon, were longer in the group of CF patients with constipation. So bloating, constipation, and dysmotility are linked, and a considerable proportion of patients who complain of bloating acknowledge that their abdominal symptom is related to bowel habit. Bloating develops as days go by without a bowel movement and resolves with evacuation. Conversely, the incidence of bloating in constipated patients is high, up to 80% in some studies. Dr. Patel showed us this image in his talk. Patients feel bloated when there's both an issue with impaired propulsion and a resistance to gas flow. And as previous studies have shown us, there is impaired propulsion due to reduction in propagating pressure waves and uncoordinated contractions. Additionally, these patients have this thick inspissated mucus in stool that acts as a resistance to gas flow. It also results in focal intestinal distension from the fecal load, and retrograde relaxatory reflexes are sent to the proximal gut, further worsening gas accumulation, retention, and distension, all of which may result in bloating. Additionally, colonic stasis may result in increased fermentation of colonic contents by the intestinal bacteria and increased gas production. So this is another study looking at the relationship between dysmotility and bloating. using enteric MRI to identify the differences in enteric content, motility, and colonic diameter between patients with bloating and healthy controls. And these were their key findings. They found that there was reduced right-sided intestinal motility. There was increased ascending colon diameter, suggestive of a large fecal load, and fecalization of the terminal ileum due to the increased fecal load and delayed emptying, resulting in stasis and dehydration. And while this wasn't a study performed in CF, these are common findings and part of the pathophysiology of the symptom burden in patients with CF. When we think about the high prevalence of bloating in patients with constipation, it suggests that the initial management should be aimed at ensuring that constipation is adequately and aggressively managed. And indeed, many of the therapies advocating for the treatment of bloating are primarily improved at improving the transit of stool through the colon. It also remains the first step in addressing bloating in our bloating guidelines. So what happens when you take laxatives? Does that impact bloating? And this is a mice study, and it compared mice, CF mice getting osmotic laxatives, linaclotide, tenapanor versus nothing. And they noticed a few things. There was improvement in transit, there was a reduction in mucus accumulation, and a reduction in bacterial overgrowth. In individual clinical trials, linaclotide decreased all abdominal symptoms, of which bloating was the most prevalent. Another preliminary report suggests that 1 in 3 patients with bloating and constipation do experience relief with linaclotide. What about prokinetics? So prucalopride is a prokinetic agent. It's a 5-HT4 receptor agonist. It increases acetylcholine and stimulates the contraction of the longitudinal muscle layer of the colon and relaxation of the circular muscle layer, and results in the propulsion of luminal contents. Specifically, it causes these giant migratory contractions. And its impact on bloating at the 2 milligram dose, it has a large effect. In constipation, it accelerated small bowel and colonic transit and emptying of the proximal colon. Clinical trials have shown us that patients treated with prucalopride compared to placebo had 3 or more spontaneous bowel movements a week. They had increased number of bowel movements with normal consistency, shorter median time to first bowel movement, and number of bowel movements with severe or very severe straining. It also showed an improvement in bacterial loads. Let's transition now and talk a little bit about dysbiosis. So why do patients with cystic fibrosis develop dysbiosis? And there's a lot of reasons. One, these patients have frequent antibiotic use. They are consuming nutrient-poor diets, low in fiber. Their gastric acid, which normally sterilizes ingested material like swallowed airway mucus, is often suppressed therapeutically. There's reduced pancreatic, biliary, and crypt enterocyte secretion that results in impaired flushing of the intestines, acidification of the lumen, and fat malabsorption. There's also accumulation of surface mucin in the poorly hydrated acidic lumen of the CF intestine that allows for bacterial adhesion and proliferation. And there's altered protective function of the mucin itself. And all of these things create an environment that favors the growth of bacteria that's capable of fermenting undigested substrates, and may result in the increased production of gases. And when we think about intestinal dysbiosis, we can divide it into small intestine and large intestine. And in the small intestines, we know that patients with CF have an increased prevalence of developing SIBO, or small intestinal bacterial overgrowth, approximately 30 to 40%. So how does SIBO cause bloating? Well, in SIBO, there's a pathologic microbial colonization resulting in epithelial injury and loss of brush border enzymes, which are in charge of breaking down carbohydrates. This results in carbohydrate maldigestion, and these undigested carbohydrates get exposed to the bacteria, which ferment it and create substantial gas production. Additionally, these slowly absorbed short-chain carbohydrates like fructose and mannitol create this osmotic effect, increasing intestinal water content and distension, all of which contribute to bloating, distension, and flatulence. So what happens when you treat SIBO? Does bloating improve? And treatment includes trials of antibiotics like rifaximin and metronidazole. Randomized controlled trials have shown that rifaximin has better efficacy and tolerance than metronidazole in the treatment of SIBO for adults. Laxatives such as polyethylene glycol have also demonstrated efficacy by facilitating that expulsion of bacteria and mitigating gut stasis. Studies have shown us that rifaximin does result in bloating improvement compared to placebo and reduction in subjective bloating severity scores. And what about colonic dysbiosis? Well, there's a reduction in the diversity of organisms. There's an increased abundance of gas-producing pro-inflammatory bacteria and a decreased abundance of SCFA-producing taxa. And so what role do these organisms play in bloating? Well, as Dr. Patel told us, right, in the colon, intraluminal bacteria play a role in gas metabolism by producing and consuming large amounts of intraluminal gas. And their activity, it determines anal gas output. And in CF, the volume of gas was significantly larger in patients compared to healthy controls. And the change in organisms may result in an increase in intestinal hydrogen gases, which have been linked to worsening bloating. Now, this increased gas production contributes to the distension, and the fecal load from this thick inspissated stool acts as resistance to expelling that gas. So all in all, to say that constipation, dysmotility, and dysbiosis can be integral to the development of bloating in CF. Improving bowel function and motility should be prioritized in those patients. Initiating Miralax, stepping up to prescription therapies when Miralax fails, considering laxatives and prokinetics, treating for SIBO with concurrent laxative therapy for the right patient, right? And considering concurrent DGBI management as well.
I was so eager to get going on time, I forgot to introduce myself. Hi, my name is Daniela Gardner, and I'm an adult CF dietitian down in Portland, Oregon at Oregon Health and Science University. I am honored to present my co-chair, Dr. Christopher Velez. He is a CF Foundation Digest Program trained gastroenterologist at the Massachusetts General Hospital Adult Cystic Fibrosis Center. He's also the program director of the Advanced Fellowship in Neurogastroenterology and Motility Disorders at the Mass General Brigham Academic Medical Centers, practicing in the MGH Center for Neurointestinal Health. He performs research in the gastrointestinal complications of CF-related diabetes, GI-related aspiration in CF, GRASP CF, and in CF-related constipation.
Thank you so much. So what we heard in the first two talks were two different ways in which to view bloating in people with CF. One being the disordered gut-brain interaction lens, where people have chronic pain even though things are moving along. And if we treat them as if they have IBS or functional dyspepsia, maybe people with CF will feel better, independent of whether or not we can actually give them a label of having IBS or functional dyspepsia. What we saw after that was a desire to root management of bloating in CF in the underlying disease mechanisms that are known to impact people with CF. So what we're doing now as we transition to this second part of the luncheon is to now move from diagnosis and pathophysiology to different treatment approaches that you can use in your clinic. And we'll even include a live demonstration at the end of my talk on diaphragmatic breathing. With my talk entitled Diaphragmatic Breathing for Bloating Complaints, Implications for People with CF. These are my relevant disclosures, in particular, one from Ardelyx regarding a research trial of tenapanor in CF-related constipation. I'll begin by discussing principles behind diaphragmatic breathing, why we use it in general, why we use it in particular GI conditions. And I'll end the presentation with a demonstration that I'd like you all to participate in to show you how easy it is to teach diaphragmatic breathing. I want to preface this by saying that there are different schools of thought on exactly how you should position yourself or the amount of time spent in the inhalation, hold, exhalation cycles of diaphragmatic breathing. But just having a framework to start can be very useful as you begin discussions about constituting your own programs, a diaphragmatic breathing training pathway, so that people with bloating can have this as a tool to manage their complaints. What is diaphragmatic breathing? Diaphragmatic breathing is a breathing technique using the diaphragm instead of chest muscles in order to breathe in. The goal is to improve respiratory efficiency and stimulate the parasympathetic nervous system, the rest and digest arm of the autonomic nervous system. No matter what exact mechanism or timing you use for your diaphragmatic breathing sessions, generally you are inhaling deeply, allowing the abdominal wall, the abdominal cavity and the abdominal wall to rise. You hold in your breath for a period of time, and then you exhale slowly in order to help reset that parasympathetic nervous system. The theory being that doing this can help improve bloating complaints after they have developed, or maybe even you can employ this type of breathing technique when you have the premonition that you're about to bloat. And in general, you practice while seated or lying down. You practice it for a substantive period of time, 5 to 10 minutes, a few times a day. And then you start getting into the habit, and this allows you to reset your parasympathetic nervous system. You are thought to engage the nervous system during diaphragmatic breathing. It helps to dampen down those fight or flight responses that can sometimes be activated in the setting of chronic illness or in the setting of chronic abdominal pain. It's also thought to introduce decrease intra-abdominal pressure. My colleague Darren mentioned the abdominophrenic dyssynergia, which is thought to underlie some patients who have a complaint of bloating. And it's also thought to enhance gut motility. Diaphragmatic breathing can help enhance peristalsis. It can help with a relief of gas distension. We do use diaphragmatic breathing in other GI conditions. So for example, in irritable bowel syndrome, we use diaphragmatic breathing. It is thought to help with reductions in bloating, with urgency and visceral pain. I'm sure some of this is resonating you with the complaints that some of the people who have CF have in your practices in terms of symptoms that they have. It can be used in conjunction with cognitive behavioral therapies or hypnotherapy when you're trying to reduce the pain burden that exists in IBS. And in people who have constipation, predominant irritable bowel syndrome, it can help to support pelvic floor relaxation. In functional abdominal bloating, it helps to improve that abdominal accommodation, and it retrains those paradoxical abdominal wall contractions. And for belching spectrum complaints, including belching disorders and GERD, it's thought to reduce aerophagia or air swallow, and it's thought to reduce episodes of reflux by interrupting belching. This is an example of the way that we think about the use of diaphragmatic breathing in a GI condition, in this instance, belching. It starts off with a swallow. You have this cycle of a premonitory urge, a habitual diaphragmatic contraction to address the urge. You end up having closure of the upper esophageal sphincter and oropharyngeal apparatus. Then you have air entering the esophagus that then you resolve it by belching it up, and you have resolution of the urge. And diaphragmatic breathing helps to arrest this progression of events through these two different elements in the case of belching, which is not what we're talking about in this talk. We're focusing more on diaphragmatic breathing as it relates to bloating, but this is a good example of how we root something which can sound sometimes a little wonky, a little hokey, like, oh, you mean breathe my way to feeling better after feeling bloated. A lot of patients sort of look at you like you have two heads when you describe this as a treatment approach. But this is the way that we view diaphragmatic breathing application in different GI conditions. So in diaphragmatic breathing, what you're really emphasizing is getting that belly to rise, the abdominal wall to rise, versus having your chest wall rise. And in conditions like belching, for example, if people are having excess belching after eating, you can then teach people to do diaphragmatic breathing during or after eating in order to reduce the risk of belching. And you have them practice diaphragmatic breathing along with other behaviors such as eating smaller amounts of food or placement of the tongue in order to reduce belching episodes rooted in that diaphragmatic breathing principle. Different approaches exist to the application of diaphragmatic breathing. It's something that once you kind of get good at it, at least I recommend when I'm starting counseling patients on using diaphragmatic breathing to at least try twice, 2 times a day. But then once it becomes habitual, you know, oh, I feel bloated after I eat. Let me do some diaphragmatic breathing exercises before and immediately after the meal in order to reduce the risk of having a complaint of bloating. And it becomes almost second nature once you start practicing it enough. So what I would say, it often takes a lot for both clinicians and their patients to get their mind around diaphragmatic breathing. It is something that is non-pharmacologic. It's a way to help relax the abdominal wall muscles. It's a way to stimulate the parasympathetic nervous system. There are digital tools and applications that can be used in order to guide patients as they implement diaphragmatic breathing. And I work in a center where we refer patients to nurse practitioners who teach diaphragmatic breathing. Other centers will have physical therapists that can do this as well. And this can really maybe not be the complete cure for a patient's bloating complaint, but offer an additional tool for a persistent, stubborn complaint. And with that, I'm actually going to lead you all in a diaphragmatic breathing exercise. So I want you all to kind of just start getting a little bit loose, put your feet firmly on the ground. I will step away from the podium so that you can actually see what I'm doing. When you are starting diaphragmatic breathing, you sit straight up or you're lying down. Legs should be uncrossed and feet flat on the ground. All right, I may just have to project a little bit. So what I want you all to do now is to place one hand on your chest, another hand on your abdomen, with your pinky just above your belly button. And what you want to do is imagine there's a balloon in your abdomen that you're trying to fill. You're trying to really prevent your chest from rising. And what I'm going to do is I'm going to lead you in an exercise where you inhale over the course of 5 seconds, you hold over the course of 5 seconds, and then you exhale over the course of 5 seconds. Some practitioners will have the exhalation be a little bit longer. Just for ease of teaching, we'll do 5 seconds, 5 seconds, 5 seconds. So I want you all to watch me first and to see what is happening. Not really come here. All over. So pinky above the belly button. I'm going to inhale for 5 seconds. Hold for 5 seconds. Exhale 5 seconds. And what I tried to do was not move my chest wall at all and to bring in the air into my lungs only by using the abdominal wall. So let's do it together. Inhale for 5 seconds, hold for 5 seconds, exhale for 5 seconds. So let's inhale. Your belly should have, we're going to hold for 5 seconds. And now we're going to exhale. Inhale for 5 seconds. Hold for 5 seconds. Exhale for 5 seconds. That's all it takes to do diaphragmatic breathing. Some of you may have felt some challenges that you may run into. People with extensive advanced lung disease may have a hard time holding their breath for that long. Then make it 2 seconds, make it 3 seconds. The goal is to really use your purposeful thinking behind your breathing in order to help reduce that discomfort that you feel. And it can be, we usually tell people to do 10 cycles of that twice a day at the start. Then it becomes less weird. And then once you start practicing it, then you are more likely to continue its use throughout the course of the day to improve your symptoms. Thank you. And now we're going to end before we start taking questions with Kristen Wright, who's going to provide the dietary perspective of how to manage bloating. So Kristen Wright is a pediatric dietitian at the Dornbecker Children's Hospital in Portland. I probably butchered that pronunciation, I'm sorry. Oregon. In addition to supporting cystic fibrosis patients, she also has worked in a variety of clinical, outpatient, and community settings. Kristen brings a compassionate, patient-centered, and evidence-based approach to medical nutrition therapy. Kristen Wright.
Great, thank you. I feel very lucky that I got to follow that breathing exercise. My parasympathetic system's all downregulated. So I'm last to present, so I promise to do my best to keep this as lively as I can. I'm calling my part deflated, which is of course dietary interventions to address bloating. I have no disclosures. And then as an outline, so generally with troubleshooting, we start with the obvious and simplest changes and then fine tune as needed. So that's how I've organized this information. We will start by some basic things to prevent air swallowing and then move into cystic fibrosis specific interventions and then move into interventions for disorders of the gut-brain axis. And then lastly, touch on tube feeds. So aerophagia, literally air swallowing. And as you can see here, the interventions are fairly simple to implement. First being to avoid chewing gum and hard candies. If this does come up in an evaluation, do take note if somebody is using a sugar-free version, and we will touch more on that in a few slides. Frequent straw use can also increase the amount of air swallowed. For children, it's good to think about the cups and straws that they might be using and if they are flow controlled, as too slow of flows or too fast of flows can also contribute to air swallowing. And if you are trying different vessels and you don't see an improvement and maybe still notice issues with some air swallowing, it's not a bad idea to be evaluated by a speech therapist or occupational therapist. And that kind of segues over to feeding difficulties too. We are most likely not going to be completing formal questionnaires, but we really just want to be listening for those oral motor difficulties with feeding in children and listening for any difficulties chewing or swallowing or choking or gagging with fluid intake. And then lastly, eating too quickly can also lead to air swallowing. So this is a really great time to focus on those mindful eating techniques. Some of my favorite being try to eat with your non-dominant hand, fully swallow before taking your next bite, or setting your utensil or food down in between bites. And then moving to CF-specific interventions, we'll touch on enzymes, constipation, and some general dietary changes. So when a person with pancreatic insufficiency is having bloating, usually we start with enzymes, at least the dietitian does. And we are reviewing, is the enzyme dose appropriate? Digging a little bit deeper to learn about meals and snacks, when people are eating, and then also thinking about what those meals and snacks look like for somebody who's not eating frequently. Maybe they're having one or two very large meals in a day. A fat gram enzyme-based approach might work a little bit better. Also thinking about when enzymes are taken in relation to the meal, it's really easy to just get in a flow and check boxes and ask how many for what. But when we do a little bit more digging, we might find that for whatever reason, somebody's taking their enzymes halfway through the meal. So ensuring that they are taken at the start of the meal can be a really easy fix. And for our slow eaters, adults or children, splitting the dose, if the meal is more than 45 minutes, splitting the enzymes where half are taken at the beginning and then half taken more toward the middle of the meal might be a solution. And then it's always great to probe about what foods are eaten without enzymes. For a dietitian or a medical professional, if we say simple carbohydrate, that can mean something very different to us than to the people that we are working with. So getting a list of foods of what people consume without enzymes can also be insightful. And then also thinking about compliance, which I know comes up for so many people. And in these situations, we should really be doing our best to identify barriers and collaborate solutions versus taking a more punitive approach, just take your enzymes. So, of course, we always want to be mindful of proper storage. We don't want enzymes to be stored in the hot cars in the middle of summer or in the very moisturous bathrooms. And then checking expiration dates. If all else fails, we can also consider a different enzyme brand, a bicarb buffered enzyme, or consider acid suppression. And then constipation management in CF, and which we are talking about because constipation can lead to bloating. So generally, to manage constipation in a person with CF, we do want to ensure adequate hydration and adequate fiber intake. Although do note that usually those two things alone might not be fully adequate. And so we might also need to use those in conjunction with an effective laxative regimen. And good compliance with enzymes, as we just reviewed. When we think about enzymes, we're often looking for loose stools as signs for malabsorption, but undigested fats can also be causing constipation. So that is an important symptom just to think about when you are evaluating enzyme dose. And then increased physical activity is a great way to get all things moving in the body, particularly focusing on those whole body movements. While we know the benefits of strength training for bone health, if you're sitting on a couch doing some bicep curls, that's probably not going to do as much to get your bowels moving as going for a walk. And then in the last slide, I talked about adequate fiber intake. So for a person with CF, this is the same as the general population. And in general, we know that lower fiber diets are associated with constipation. So really what we're aiming for is the RDI for fiber. And taking note that a higher fiber diet above and beyond that might actually be exacerbating some GI symptoms and contributing to bloating and abdominal pain. And then anytime we are adjusting fiber in the diet, we do want to ensure small gradual increases and make sure that is followed with fluid, mostly water if possible. And then also keep in mind that this is not a one-size-fits-all approach. So a lot of times we will need to do some individual tailoring. And then fluid and fiber go hand in hand. So when we're talking about fluid, the best way to hydrate is consistently throughout the day with meals and in between meals. For some people, it can be helpful to have a cup for some self-monitoring. So for example, this is my favorite cup. It has 24 ounces. I set a goal to have 3 of these a day. And that kind of approach can work really well for children as well to monitor their intake. If fluid drinking doesn't get you there, also including high content foods can be a great option, especially if we're thinking about somebody that might have sensory processing disorders and doesn't like the wetness. High fluid content foods that I have listed up here are another great way to support adequate hydration. And then when we're thinking about beverages within the scope of bloating, we do want to limit or avoid carbonated beverages to reduce excess gas. One caution I would put out there would be flavor additives or the water enhancers, non-nutritive sweeteners, because these can contribute to gut microbiome dysbiosis and the sugar alcohols might be problematic. Now moving on to larger picture and thinking about diet as a whole, the legacy diet we know is high in energy and fat and tends to be lower in fruits, vegetables, whole grains, and legumes, thus lower in fiber. However, now with our new modulator medications, we are seeing that it can be more appropriate to transition and shift toward a more general, healthy, balanced diet. And there is evidence that incorporating more whole foods and shifting toward a Mediterranean-style diet can actually alleviate and improve GI symptoms. Oops, got ahead of myself. So thinking about why those shifts might be helpful, it's very likely because a higher fat Western-style diet does contribute to more dysbiosis of the microbiome when we compare it to a Mediterranean-style diet. And then along those same lines, people that have a high intake of easily digestible starches and sugars can also contribute to dysbiosis, as well as the use of non-nutritive sweeteners. And for all of you visual people out there, I really like this graphic to show a comparison of diets. And you can see how the Western diet is probably the closest to the legacy CF diet and has a really strong effect on the microbial diversity and the mucosal layer, whereas that Mediterranean diet does improve microbial diversity and supports a healthy mucosal layer. So thinking back to the presentations that we just had, that really kind of helps us understand why this improved microbiome may help alleviate bloating and GI symptoms. Okay, so now we're going to shift. As my predecessors have reviewed, DGBIs can be challenging in CF because we have a disease that can explain many of these symptoms. But I'm sure many of us have experienced, we've optimized everything CF specific, like we've just discussed, and then we still have people struggling with GI symptoms and bloating. So there is very limited research specifically on dietary interventions to address bloating in CF, but we do have research on dietary interventions for people without CF that have been diagnosed with DGBIs. So that's what we're looking at now. So we've already reviewed fiber needs for someone living with CF and how that can affect GI symptoms. Under the DGBI umbrella, there is research about the specific type of fiber. So the insoluble fiber, which is that fiber that does not dissolve in water, so thinking things like bran, which we're going to find in whole grains or whole wheat bread, nuts, fruit skins, just to name a few, those have not been found to be helpful. However, soluble fiber, so the stuff that does absorb the water and becomes viscous and gel-like, has been found to be helpful. So when we're talking about increasing fiber, this is the direction that we want to go. And I've included some food sources just for reference. And when we can't get it through foods, there are supplements that can be used. Just note that psyllium has mixed. Some people tolerate it, some people don't. And then generally when we're looking at supplements, it's not as well studied in pediatrics. So we really should try and push more toward those food sources. As the pediatric dietitian and the mother of a very selective eater, one of my favorite ways to include some of these foods is using oat flour. So literally just taking oatmeal, putting it in a blender, blending it into flour, and then using it in baked goods, or adding ground flaxseed, ground chia seed. This works especially well for pancakes and waffles. And if you have any other ideas, please share with us. And on to FODMAPs. So as the name implies, FODMAPs are the group of foods that contain certain types of fermentable starches that when reduced or eliminated, they may alleviate GI symptoms in DGBIs, including bloating. And this is probably the most studied and evidence-based dietary intervention for adults, and specifically those experiencing symptoms with the consumption of food. So that's somebody who eats something, I'm having bloating afterwards, that gets a little bit better after as time goes on, versus somebody who has that kind of ongoing symptom regardless of meals. And just note that in kids, there's less data, so we want to use a little bit more caution if we are using this for younger people. So each of the different FODMAP groups do have different effects. So the smaller molecules, the mono and disaccharides, are most often associated with increased osmotic activity, and their digestion and activity is happening more in the small intestine, whereas the larger molecules are the ones that are making it to the large intestine and interacting more with the gut microbiota. And of course, you can see there's a lot of overlap, which makes it tricky. This is a different view of the same information, but here it's separated out by small and large molecules. The biggest take home from this slide is that while all high FODMAP foods can lead to bloating and distension, there are more ways that the large molecules have this effect. And that's also what research suggests as well. Fructans and galactans, which are the oligosaccharide part of FODMAP, are more associated with those symptoms of bloating and distension. Here we're looking at the actual foods. Fructans and lactose, which I have in the boxes here for you, are the most common offenders for bloating. So fructans, which are one of those oligosaccharides, the bigger, larger molecules, is most often found in wheat, garlic, and onion, which is super prevalent in a lot of people's diets. And then lactose is a disaccharide, which is one of the smaller molecules, but also really strongly associated with bloating, which most of us know is associated or found in dairy foods. So as these are the most common offenders, I would just be thinking about these foods when you are hearing about someone's intake and their diet recall, and really consider the frequency of their intake and also the quantity of the intake. Fructose and polyols tend to have less of a gaseous response. Those are usually more associated with loose stools, but bloating can still happen. So when we were back at the beginning, talking about chewing gum and hard candies and non-nutritive sweeteners, a lot of those foods are going to be the foods that have sugar alcohols. And so if somebody has a high intake of that, that might be why. Now, formally, the low FODMAP diet is an elimination diet, which is really only appropriate for somebody who is motivated, has good support from a dietitian, and has the resources to be able to implement that diet. And it's not a full elimination forever. It's a short-term 4 to 6 week elimination. And the idea is that once we take out those foods, all of our GI symptoms are magically fixed and go away. And then we can start reintroducing foods to really figure out which foods are the offending foods. And then we can fine-tune from there. As Dr. Patel said, we always want to use caution with elimination diets, eating disorders, risk for malnutrition. People with food insecurity, it might just not be appropriate for them. So there is a version called a simplified low FODMAP diet, where essentially we are taking this knowledge that we just learned about FODMAP foods and using a food frequency questionnaire or a food symptom journal to help identify the intake of frequently consumed FODMAP foods. And then from there, we can try some food eliminations and reintroductions to try and find those foods that are causing symptoms. This is a fantastic approach in my opinion, but is not yet proven. Just a heads up. And then I'm sure many of us have heard people reporting that following gluten-free diets have drastically improved their symptoms, which is also supported in observational studies. And then when we're thinking back to the FODMAP foods, mostly the fructans that we just talked about, wheat and wheat-containing foods is one of those foods that was most associated with bloating. So it is very possible that it's not the gluten that's the problem, but it could be the fructan, which is concurrently eliminated when we follow a gluten-free diet. So a good test that you could do in this situation would be to trial a low FODMAP gluten-containing food, such as a bread made with spelt flour, to help distinguish between a fructan sensitivity or a gluten sensitivity. Another anecdotal thing that you might hear is someone tolerating sourdough bread more than conventional bread. And it's not really unreasonable when we look at it, because commercial breads are yeast leavened. It's a relatively short fermentation time. So really only those simple sugars are being used and broken up in that fermentation. Whereas the sourdough has a much longer fermentation time, which allows for more breakdown of those larger molecules like the fructans, leaving fewer in that final product to be fermented by our guts. So if you have identified someone as sensitive to fructans, but maybe they're missing bread, trialing a sourdough version might be an option to look into. And now that we're talking about microbes again, this is a good segue into discussion of probiotics. There is evidence that probiotics might be helpful in the CF gut to reduce intestinal inflammation, but we really don't know what this means for bloating. And then outside of CF, similarly, there's also just not enough research right now for us to make a blanket recommendation for a probiotic to treat IBS symptoms. That being said, when we do look at the research that is there, it seems like the bifidobacteria strains are the ones that would be most likely to help with bloating specifically. And then those that are very desperate for bloating relief might come to you asking about other supplements that they can take. So there are a whole slew of herbs and spices that have reported benefits for GI symptoms. However, as with most complementary and alternative therapies, there's just need for more research, especially in pediatrics. Peppermint oil and caraway oil are probably the most studied, but they do come with quite a list of side effects. Kiwi fruit is also being shown to have promising outcomes. So all of these CAM therapies could be their own presentation. So I'm going to leave it right here for you, but did want to just touch on this and then share these resources for anyone who might find that helpful. And then last but not least, I did just want to touch on interventions for bloating and those supported by tube feeds. You can see there are similar situations for fiber intake with an oral diet, as with an oral diet. However, for people with pancreatic insufficiency, fiber-containing formulas fiber-containing formulas might be limited depending on whether or not that person can take oral enzymes or if they need to use the digestive enzyme cartridges that aren't necessarily compatible with all types and quantities of formula. So there are some simpler modifications as well, such as temperature or rate that can be changed and bring some relief, or even thinking about venting or a gastric decompression like a Ferrell bag can be really helpful. And then putting it all together, we should always be starting with CF-specific interventions first. Now that we have highly effective modulator therapies and don't have to push that legacy diet as much for as many people, really focusing on diet quality can be beneficial and a great place to start. And not just for bloating, but for overall health and longevity. And there is very limited research on dietary interventions for DGBIs, specifically within the CF population. So if you are going to move the direction of low FODMAP or gluten-free, just keep that in mind and use caution. Using modified approaches, such as food symptom journals, might be a little bit more helpful and easier for people. And then when it comes to probiotics and CAM therapies, these should always complement other changes. Dr. Will Bolsevec said it best: you can't out-supplement a bad diet. And really, the last point I want to stress when it comes to dietary interventions for bloating is there's just so much left to learn. So much of the information I've presented has not been specifically studied in CF, but I did want to build awareness of all of the interventions that may come with these conversations so that we as providers can help provide informed and shared decision-making.
So now we're going to open up what wonderful presentations today that really describe the framework that we used when approaching bloating, as well as potential treatments. As some of you are starting to make your way up to the microphone, we have a couple questions that have come in. So the first question was, why do you think that some CF patients feel worse, don't tolerate Miralax as a laxative? Is there an alternative laxative you recommend for these types of patients? Kirthi, do you want to take that?
Sure. So I mostly treat adult patients, so I'll come at it from that standpoint. There are a few patients that I find, maybe more than a few patients, that don't respond to Miralax, have really very minimal changes, if anything, to Miralax. And, the first step is to make sure what's going on from a bloating perspective is that the issue is constipation, right? Is the issue constipation, or is there something else going on? Once you've identified that what it is that they have a large volume of stool that's contributing to symptoms, then you can consider upstaging therapy. I think a big thing that limits us is insurance approvals, and what insurance is going to cover in terms of next step agents. From a next step agent, I generally tend to think about linaclotide, so Linzess or Motegrity or IBS Rela. I don't tend to go to Amitiza, and other people can tell me what they do as well in their practice. And this is mostly from my studies in CF, but it's the one agent that predominantly acts via the CFTR pathway. And so at least in my studies, they don't see any change in intestinal transit. They don't necessarily see that improvement in small bowel and colonic transit. Now, in the few studies that we have in patients with CF, it's very mixed reviews, but I anecdotally haven't had as good response with Amitiza.
Darren, do you want to offer the pediatric perspective?
Sorry. So yes, I agree. For a lot of literature, we don't really have information on pediatric, and I can more comment on ped side. Miralax package insert, says 2 weeks at the max. We all know that that's not entirely true. And I think it's more of a texture issue for a lot of kids, especially with autistic patients. And, they're super smart. They figure things out in their drink. Because none of the tube feeders ever complain about the Miralax being intolerant, right? Like they don't really care, and I think that's one of the good medicine that we have. And, you need to build a concentration in the gut for it to work. As far as other medications, I think Chris is leading some trial in CF patients with tenapanor, like he said. We don't really have data other than linaclotide, which is now approved for, a good range of patients, even in pediatrics. I don't have a lot of experience with other medication except the prucalopride. Prucalopride is one of the good medicine for many conditions, but particularly CF, where 5-HT4 agonistic mechanism, that works throughout the GI system. It can cure or not cure, but it can, help with the ineffective esophageal motility. It can help with the gastroparesis patients, small bowel dysmotility, and slow colonic constipation. So I think looking at entire picture, I think this is like someone said earlier, one size does not fit, and you may have to use the combination. I don't tend to use Amitiza or other medications anymore because we have more powerful agent.
So as people are hopefully starting to make their way to the microphones, I'll offer my perspective. Since the second question that we got electronically was people's experience using linaclotide, the generic for Linzess. So we're going back to Miralax, when people say it doesn't work, I ask them what they mean by it not working, because sometimes it doesn't work because they haven't had a bowel movement in 8 days, and they take a capful of Miralax and expect to have a full bowel movement. And that's just not how Miralax works. So I determine frequency, how much they're using. Sometimes what's nice about Miralax, although I entirely agree with the texture concern, is at least you can easily scale it. You go too much in one capful, go half a capful, go a quarter capful, go 2 capfuls. It lends itself to easy titration. Regarding the question from the audience regarding linaclotide, so I think for those of you who are not CF-focused gastroenterologists like Kirthi and Darren and I, what I want to say is where I think I see most patients having their GI symptoms not adequately managed are when people seem to think that it's Miralax, Bisacodyl, Senna, and they stop there. And they or docosahexae colase. And a lot of the newer agents that we've been trained to use over the course of our training have been available for 10 or 15 years, but they are well studied. Linaclotide, lubiprostone, plecanatide, prucalopride, and tenapanor. Although the debate and part of what Darren was alluding to with my research, you sometimes then have to give an IBS label to someone who has CF-related constipation, and then the insurance companies will say, well, they don't have IBS. Why are you prescribing linaclotide? So you have to be judicious with documentation to make it get approved. Linaclotide I have a good experience with in people with CF-related constipation. I may shy away from it if people have mutations that aren't modulator eligible because it does go through the CFTR pathway. That's when I may be more likely to lean on prucalopride as a prokinetic to help improve GI tract motility.
Although it can work independent to CFTR channel too.
Yes. So that's why I will never say, no, you're not eligible for linaclotide. Any questions from the audience?
Oh.
Thank you. So I have a question. With diaphragmatic breathing, does it matter if you breathe through your nose versus mouth? This is where you've exposed the limit of my knowledge of diaphragmatic training. I tend to do in through the nose and out through the mouth because that's sort of the deep breathing that I counsel people on during moderate sedation colonoscopies when they're feeling uncomfortable, is to breathe in deeply through the nose and out through the mouth. Do you guys?
So again, our patient population, they don't exactly quite follow what you're asking to. So a lot of patients with rumination, that's where we try to ask for diaphragmatic breathing, and they are by default mouth breathers, many patients. So I think mouth breathing is fine, but I don't know 100%.
Yes.
Yeah, I have a question about the prucalopride. I've been trying, so I'm an adult gastroenterologist. My name is Linda Cummings. I'm in Cleveland at University Hospitals. I've been trying to put patients on prucalopride oftentimes before I've tried any other of these newer agents, but I run into so much difficulty with requirements for prior authorization, and most of the time these insurance companies are requesting that the patient be put on linaclotide or plecanatide first. Do you have the same kind of experience? And if so, do you have any suggestions for how to kind of get through that process a little bit faster?
Yeah, I think we're all facing the similar issue. So I do agree with that. Sometimes using the combination of diagnosis of constipation and gastroparesis together will help you the most. I don't know everybody, and this is I don't know if I'm supposed to say it's playing the system a little bit here, but if you have diagnosis on the chart, both combined, it's easy to get approval to some extent. But it's not uncommon for us to see that kind of request that, hey, have you tried this or that? And a lot of this is like, guys, they're not even approved for pediatrics and you're asking us to use it. And, so what's the difference between this medication? I think I overall it comes to cost. So you're not alone. But I'm surprised that you're having difficulty as an adult GI. I mean, a pediatric GI, yeah, we're not important. I mean, we know that. But adult GI should be primarily like getting all these approvals.
We do, so sometimes there's no alternative but to try the linaclotide and lubiprostone and see what happens. Clearly documenting IBS-C, even if it's CF-related constipation, because they do meet symptom-based criteria for IBS-C, a lot of the patients with CF-related constipation. And then documenting clearly tried linaclotide fail, tried lubiprostone fail, that's why you're prescribing prucalopride.
This is going to be unpopular, but after I get my first rejection, I always do a peer-to-peer, and then I explain the pathophysiology of CF, and that does seem to get it approved, but it is frustrating. It helps that it's just for the CF patients that I do that for, but it is frustrating. Yeah, we have that issue.
Sometimes they'll bully and threaten that they're going to provoke an unnecessary hospitalization, a potential compromise from DIOS. As how could they dream of putting particularly effective after someone's had a lung transplant to make that argument? Like why? And I feel like you scare them enough that way, they will be more likely to approve. Some more questions that have come in. One was a variant over an earlier question. A handful of patients refusing to use Miralax because of increased bloating. Any suggestions for them? I would just sort of maybe try dampening down the dose. So maybe trying half a capful of Miralax, maybe doing a capful of Miralax every other day would be an approach. And an interesting question, the role of stimulant laxatives. Do we not use them? Kirti.
I don't generally tend to go to stimulant laxatives. Usually people will come see me, they're already on stimulant laxatives. I just find that they tend to be less tolerated. I don't know if you guys feel that in your practice. They tend to, for especially the CF patients, I see a lot more like cramping, more diarrhea. They just don't seem to be tolerated that well.
Again, I have a different opinion on that. Stimulant laxatives
Continue with a good point counterpoint.
I do agree with Kirti for most. This is not, this is just a friendly frenemies, I guess. So stimulant laxatives are, it's anthraquinone derivative. So it's a plant product. And it works through enteric nervous system. So it's not really, I think the literature came from like older, not even experiments, mouse model, like the dependency question. Now, if you have small kids, there are patients who will have an encopresis, leakage of stool all the time, right? The reason being rectosigmoid dilation. And once you reach to encopresis stage, you have dilated rectum enough that there are no reflexes. The kids don't sense that they're pooping their pants, so at that point in time, just doing Miralax alone will increase the leakage, and we're like, oh, not responding, but really they need to feel those cramp. So I do use a lot of stimulant. In fact, we wrote the guideline on refractory constipation in pediatric patients. Anyone can guess, how high stimulants can go, what the expected dose. You can have 15 milligram chocolates, but 8 of those a day in pediatric population. So like about 8 of those a day, it's a lot of senna. But if you respond and if you are tolerating, then you save yourself from a lot of other social and, other problems. So I do use it. Yes, it might cause some cramping, vesicodil or senna, but I feel more encouraged by, a couple of other studies now that actually proves the whole notion of like being dependent wrong. In fact, the study showed one of my mentor, Leonel Rodriguez at Yale, I shouldn't say proved, but he showed that patients with, if you use the high dose stimulant, you're going to treat the constipation faster and better, and you'll be off of the medication sooner than you play with it, for a long time by not using it because of the dependency question.
So I would say I would agree that this mythology that if you use stimulant laxatives, you become dependent on them is myth. It's not what we see on the GI side of things. I tend to use stimulant laxatives if, let's say, it's more of a frequency concern, like someone doesn't have a bowel movement every 3, every 4, every 5 days, then I just physically want to move things along. Well, I do people that end up getting them not knowing that when they take too high of a dose of laxative, that their abdominal pain is probably from too much stimulation. So then they think that's a reason to take more stimulant laxative. So sometimes getting a reset and sort of like saying, let's just stop for a couple weeks to see what happens. Another question that came in, what is more effective for bloating relief, walking after eating or diaphragmatic breathing? I'll take that one. A lot of the issue with a lot of the studies that are for diaphragmatic breathing, and you'll see the reason why I didn't put too much literature on there, is that the studies are not high quality or large or involve a large enough number of participants. There are cultures that have a defined after meal walk, like the Italians with the passeggiata, where that is an important element of digestion is walking. So I would say, given the evidence that Darren mentioned earlier, probably any physical activity is good, but I don't think one is better than the other. Any thoughts on utilizing abdominal massage and or acupuncture in a complaint of bloating? I know massage isn't always covered, but would love your thoughts on non-pharmacologic management and intervention. So Kristen, when you were mentioning some of the CAM treatments, I, for example, recommend a lot of ginger as a supplement, and sometimes curcumin. I imagine you're not recommending a lot of acupuncture in your practice. How do you approach sort of the ginger curcumin discussion, if you have it at all, at the dietitian stage?
It definitely comes up, and really we just lay out the pros and cons. There's not, I guess we usually start with, there's not enough evidence to make a blanket statement. But if you want to use this and you find it helpful, then we can support. So we talk about the safe resourcing of those products, and then potential side effects.
And I would say in general, knowing what you're putting into your body as a supplement is most important. Staying away from mysterious herbal combinations that you don't know what could or could not be and represented in that accumulation of substances, since there can be hepatotoxicity. Yes.
Hillary Bashaw, PhD at Dornbecker, also part of the Digest group. I think this really highlights some of the differences between pediatric constipation management and adult constipation management, both in what's available to us and in what our patient populations will take or tolerate. And I just wanted to ask both the peds and the adult providers, in the question of using something for a stool softener instead of Miralax, I'm leaning in more to a lot of the magnesium hydroxide products. And families are coming to that on their own. I think there's a lot of the calm-based products or things that families are finding magnesium is helpful. And I have found with a lot of my teens on the go, when I can't get linaclotide approved, using the magnesium chews so that they have them available and with them has been helpful. Is that something you all use in adults, or are other peds providers using that too?
Yeah, I think it's a reasonable alternative. I think especially over the counter, and they don't have to worry about it. They can just get that 400 milligram caps and take 1 or 2 and, go on their way. One thing is about magnesium, it also helps with the sleeping, a little bit, muscle relaxation, and some patients with nausea too. So if you have whole DGBI spectrum, and that's another thing with the ginger too, this might help. In fact, Dulcolex, if you just kind of Google Dulcolex or go onto store, it's not bisacodyl. Some of the Dulcolex are really magnesium oxide preparation. So I do use it for patients who are not able to use Miralax. But again, not for prolonged time, because, sometimes there have been some cases with hypermagnesemia too reported. But I think those are far and I've never seen myself, just to kind of say, I don't know, but adults.
I've used it on occasion, particularly if I have a pregnant patient that might have constipation, but not too common. And mostly because if they want to be on magnesium, they're usually already on it. And then they're coming to me because it's not working. But I'm assuming a lot of patients are taking it. It is very popular on social media. There's lots of magnesium-based supplements that are on the market. But people do find relief from the magnesium.
And as we wrap up with our last question, turn it back over to you, Kristen, regarding if people are using probiotics in your practice, how long do they stay on it? My practice is sort of, I don't know. We don't know which ones are the formulations that you get in the store. If they're sitting on the shelf for months, the bacteria probably aren't alive anymore. But what is your approach for how long people will be on it in a dietitian perspective?
Yeah. So it's very individualized. I think when it comes to probiotics, there are so many things that can affect the gut microbiome that it's always a moving target, right? If our diet changes in any way, then that can kind of like redistribute or change the microbes that are present. And so I would say as long as somebody's having symptomatic relief and feels like it's working for them, then we can support that. But I think the minimum that I saw was maybe like a month of being on it before it affecting the gut. But as far as continuing, really individualized approach.
I don't have a better answer than that. I think what I usually tell people is what's better for your gut microbiome is to have the diet that allows for a healthy community of gut microbes. So fiber, use of, although this is a little challenging to mention in a bloating talk, but fermentable products, kimchi, kefir, kombucha, those are things that can help readjust the microbiome. And I think that wraps up today's luncheon session. Thank you, everyone. We can stay behind if anyone wants to ask questions. We'll stay up front for a little bit.